All right, well, thank you very much. I'm honored to be here, and I'm grateful for the audience for showing up so early on a Saturday morning. So, to first start off with my disclosures, I do receive royalties from Up to Date for some articles I've written, and I'm also a co-author for one of the papers that I'm going to mention. This lecture, this 15-minute talk is all about patient selection. So just to draw some limits, I'm not going to discuss treatment decisions beyond the first 12 hours. I'm also not going to discuss the nuances of endoscopic, laparoscopic, and operative techniques. That will be for the later discussants. The assumptions that I'm going to make is that you have a 24-hour operating room and surgeon availability, and you have access to resources to provide critical care, and you have backup, whether it's yourself or somebody else, to do endoscopic procedures and IR procedures. Without these prerequisites, some of the recommendations I'm going to make may not be applicable. So there's a kind of a broad universal approach to a perforated viscous consult, which is number one, do you have source control? Can you get source control without having to take this patient to the OR, putting them under general anesthesia? And number three, will the patient even survive the operation? There are two broad reasons why not to operate on someone. Either, and you hear this a lot from our colleagues, they call them at midnight for a consult, and they're like, no, they're too sick or they're not too sick enough. Well, we as surgeons can play that card as well, right? So either the patient's too sick and they're gonna die no matter what, and you're doing futile care, or they're not sick enough yet, and you have time to play around and try and get them through this without an operation. Now, why is that important? Patient selection is key, because if you were to operate on every single patient every single time, as you'll see after the next 15 minutes, you'll be doing a lot of unnecessary operations and all the attendant morbidity that comes with that. However, if you take a completely non-operative approach, then there are going to be patients that will suffer because they needed an operation as soon as possible. And you're going to have and every hour increases the risk of morbidity in that patient who needed the operation and you delayed. So patient selection is key. So here you are, you've just finished a day of elective cases, you're on call, and you get that page right at 5:01, right? Good evening, are you on call? Yeah, it's the ED. We got 4 consults for you. Awesome, thank you. Okay, so consult number 1, you have a 52-year-old female with epigastric pain for the past 2 months, but it acutely got worse last night. By the time you see her, though, they gave her some pain medicine, they gave her some antibiotics, and she's actually already feeling better. So you examine her, she's got peritonitis, she's got rebound, she's got guarding, but there are her vitals, pretty stable. She's got a lactate normal, and she's got a normal white count and creatinine. They already got the CT scan for you without oral contrast, and there's the imaging. So this is clearly a perforated peptic ulcer. Trust me, this is an actual patient that we had at Miami. And you should know that in all comers, about 50% of them will actually be candidates for non-operative management. You should also know that if you go down this route, you have to accept that about up to a third of them will fail, but that's okay, because as long as you're monitoring them in the ICU and you're ready, you probably are not gonna lose anything. Now, peritonitis on clinical exam for this disease, ulcer is actually not predictive of whether or not they're going to succeed. So really, the main thing here for diagnosis is oral contrast, and it's worth it to repeat it if they didn't get it before, because up to 40% will actually have already sealed by the time you get that scan, okay? So there have been several studies looking at this. Here's one of 241 consecutive patients. All of them had this upright chest x-ray that we're seeing right here, right? Free air, okay? And guess what? Nearly half of them were successfully managed without surgery. Those authors developed a scoring system up to 4 points based on the criteria on the left, and as you can see, you have decreasing success rate with increasing scores. All right, so that's just one scoring system that you can use. This is the only randomized trial that I'm going to present in this lecture, because it's the only one that is done in all the diseases I found. And it's basically out of Hong Kong. They randomized 83 patients to either immediate surgery or a non-operative therapy. And again, about a 28% failure rate. However, no difference in outcomes that they could detect. They did find that older age was less likely to respond. So the bottom line for this disease is older age, be a little bit, lower threshold to operate, but you got to get that oral water-soluble contrast study. okay, and then look for that contrast extravasation to help triage the patient. Air and fluid is not enough. Your next consult, 39-year-old lady, left lower quadrant pain, getting progressively worse, nausea and vomiting, and anorexia. So she's got rebound only in the left lower quadrant. She's distended and she's tender throughout. As you can see, she's mildly febrile, borderline tachycardic, and she's got normal lactating creatinine. Here's this lady's scan. In case you can't see it in the back, that's the falciform ligament. So we've got a significant amount of free air, pneumoperitoneum even. Okay. In perforated diverticulitis, CT scan is the way to go. All right? I mean, I think we're probably preaching to the choir here. There's two studies that I'm going to present to you. This first one is by Ari Lepaniniemi's group out of Helsinki. 132 patients, all with extraluminal air, who were trialed first for a non-operative management trial. They actually excluded patients with generalized peritonitis, and they defined distant air as greater than 5 centimeters away from the inflamed bowel segment, and 85% of those patients actually succeeded in non-operative management. All right, so if you break them down according to where the air was, it was just pericolic without any abscess, and it was just a couple bubbles within 5 centimeters, 99% success rate. However, going down to distant retroperitoneal air, you see that the success rate is lower, but still nearly 50%, okay, but they had increased morbidity. So that's why the CT is important to measure how far away from your inflamed segment are you and what is your likelihood of success. Now, this other group later on, Titos Garcia et al., they went ahead and used the same sort of 5 centimeter distance, and they also looked at 77 patients. Again, 85% success rate in non-operative management in stable patients, okay? But then, actually, you could probably argue they probably weren't that stable because some of them had ASA 3s and 4s. All right, but high success rate if you're not that distant. So bottom line for diverticulitis, if you don't have distant air, then you can consider doing non-operative management. I cannot comment about whether or not peritonitis is accurate or not. Consult number 3, 72-year-old lady, biliary pancreatitis, went to ERCP earlier today, let's say 10 in the morning. It's now 5:01 p.m. All right, excruciating abdominal pain, febrile, tachycardic. Those are the two, at least two SIRS criteria, and lactate of 4.4 and a creatinine of 1.8, 72-year-old lady. There's mainly two. I'm not going to talk about colonoscopy, but I'm going to talk about mainly upper, EGD and ERCP, right? So the EGD, they've actually classified the types of perforations based on the mechanism and the underlying pathology, okay? So piercing, most commonly with false diverticuli going down the wrong lumen. Okay, shearing is oftentimes associated with strictures, and then bursting is with procedures such as balloon dilatation for achalasia, and then thinning has to do with either ulceration or neoplastic lesions where it just actually just erodes, basically. All right. So those are the 4 types that you'll encounter. Almost all of them associated with EGDs are associated with some sort of therapeutic maneuver. The only one that has been seen with diagnostic is the shearing type, in which you're basically trying to get through a stricture, not really trying to do anything therapeutic, but getting through may cause that shearing. So again, water-soluble contrast study. In this case, you can either do a swallow study or a CT. I prefer CT. But you also want to ask a couple of additional questions. What's the duration of symptoms? What is the underlying lesion? And is there a distal obstruction? All of these factors will come into play to determine whether or not you offer non-operative therapy. Now, presumably, the person who did it is still around in town or close by, or you have access to backup who can do a bunch of these adjunctive therapies to help you treat this non-operatively. For ERCPs, they've actually classified it into 4 different subtypes. The 4th one not really being thought of as a true injury because up to 30% of ERCPs, if you scan them all the next day, up to 30% will have pneumatosis and retroperitoneal air without evidence of extravasation. So just retroperitoneal air alone is not sufficient to operate. You got to have extravasation. Again, contrast study. So looking at the 3 types, type 1 is caused by scope trauma, type 2 is caused by sphincterotomies, and type 3s are caused by guide wire and basket misadventures. All right? And so the European Society has come out with a treatment algorithm. So If you're doing if you encounter a type 2 or 3, periampullary or wire, almost over 90% of these can be safely managed non-surgically, but that doesn't include non-interventionally, okay? You gotta get biliary diversion and drainage, preferably with nasal biliary or stenting or whatever. But most of these will be managed non-operatively. Now for the duodenal perforation, it is rare. The reason I would say the reason why the previous one is because most of them are diagnosed during the procedure itself. In contrast, duodenal perforations are rarely diagnosed during the case because of the side viewing scope, and it's not really expected. Oftentimes it's associated with unusual anatomy, like they've had a Billroth or they've had a Whipple or something. But they almost always need to go to surgery for if you have a type 1, okay? So, again, questions. Is it a contained or uncontained oral contrast study? And how much air? The air actually doesn't matter, okay, because it has to do with the insufflation rather than the size of the lesion. Bottom line, okay, type 1s, ERCP, duodenal, almost always have to go to the OR. And the other, for EGDs, there's a lot more questions that you need to consider, but you can still actually get away with non-surgical treatment for a lot of these. Okay. Final consult, sleeve gastrectomy 7 days ago. She's febrile to 38.5, heart rate 120s, otherwise normal. She has mild tenderness to deep palpation. The two types of procedures you're gonna see most commonly are gastric bypass, Roux-en-Y, and sleeve gastrectomies. Most commonly for gastric bypasses, you're gonna see the leak right there at number 2 at the gastrojejular anastomosis. Most commonly, they present between days 2 to 5. They may even still be in the hospital, and they usually have the presenting symptoms of fever and tachycardia. Once again, radiographic oral contrast study. Up to almost 90% of them are contained at the time that you get this study, and if they're contained, almost all of them are successfully managed non-operatively, but with adjunctive procedures. Again, the size of the leak is less important than whether or not they're contained or diffuse contrast extravasation. For leaks, almost all of them are gonna occur at that ischemic angle at the proximal staple line, and they're gonna occur after the patient's already discharged from the hospital. So they're gonna come back 7 days later, as this patient did, with vague complaints. However, nearly half of them are also able to be managed non-operatively. So unless they're unstable or septic, you can go ahead and manage them and try to manage them with a non-operative technique. So bottom line for bariatric leaks is that you gotta get that oral contrast study. There's a high success rate, and a lot of these are amenable to endoscopic and percutaneous interventions. So for all of these cases that I've presented, hemodynamic stability and the response to resuscitation is key. And we don't really know what the significance of generalized peritonitis, which is sometimes subjective, what is the significance in this modern era, okay? So in the last 2 minutes, I'm gonna quickly go over how do we determine how sick is too sick, and how do we diagnose, how do we counsel patients pre-op? So there's 2 reasons why somebody may be too sick. Either their cancer is too disseminated and too far gone, or their physiology is too far gone and they're gonna die no matter what, okay? So a lot of the scores that we have to help us decide are plagued with issues of subjectivity. They were developed in non-emergency cases, or they require intraoperative or 24-hour data. So this is the publication that I have to disclose I'm a co-author on. This is the Emergency Surgery Severity Score. It was developed exclusively in EGS patients with high mortality rates, and it uses only preoperative measures to calculate it. Here it is, you get a maximum score of 29. Nobody in our data set actually got above 22, okay? And so here you see they're all preoperative measures that are measured in the course of usual clinical care, and you can see a very robust and stepwise increase in mortality. We've also looked at it for 30-day complications, ICU stay, all sorts of things. It's validated across multiple operations you're gonna see, and it's even more sensitive than the ASA score, which, as you know, has a degree of subjectivity to it, okay? So bottom line, this is something that we should begin using to counsel patients preoperatively. If they have a score of 22 or higher, you can say with pretty much 100% confidence they're not gonna survive no matter what you do, okay? Finally, in 30 seconds or less, how to determine if somebody is septic. Okay, so back 27 years ago, they came up with an expert opinion-based definition of sepsis, which involved the SIRS criteria, which I discussed. Okay, patients acting SIRSy. Okay, as you know, SIRS and sepsis actually overlap a little, but there's a lot of diseases that don't have SIRS, and actually septic patients miss it. So we've realized that SIRS lacks validity and sensitivity, and so the new sepsis 3 definitions are all about the SOFA score, organ failure, okay? And then I'm gonna quickly go because I'm going over. So you gotta go, and then out of the ICU, you can use the Q-SOFA score, which will help you determine whether this patient's actually septic or not. And then regarding treatment, okay, so I'm gonna just got right to the final algorithm. This is the last slide. Okay.
You can just sum it up now.
Yeah. This is the last slide. Perforated viscus. Is this patient too sick to operate anyway? If yes, palliative care. If not, do I have source control? If you do, trial of non-operative management. If you don't have source control, okay, can you get source control? Do you have the options? If not, then you take them to surgery. If yes, will the patient even tolerate the attempt to get that source control? If yes, then go for it. If not, then surgical exploration is the key. All right, and that's it, and I am out. Thank you very much for your attention.